vielen Dank. Zunächst mal ganz herzlichen Glückwunsch an unseren Preisträger, den ich nun vorstellen darf. Er ist 36 Jahre alt, in Athen geboren und in Griechenland aufgewachsen und hat dann zunächst eine Ausbildung als Krankenpfleger gemacht, bevor er Medizin studiert hat. Neben seinem Medizinstudium hat er einen Master in Medizinalchemie und Biochemie abgeschlossen und im Folgenden seine Doktorarbeit, die medizinische Doktorarbeit und dann noch eine naturwissenschaftliche Doktorarbeit, den PhD, gemacht. Also ein ganz besonders beeindruckendes CV mit 3 Ausbildungen und 2 Doktortiteln, das wirklich hervorzuheben ist. Seit 2019 ist er in Deutschland als approbierter Arzt tätig und er ist am Klinikum in Hamburg in der Abteilung für Allgemein und Viszeral und Thoraxchirurgie tätig und gleichzeitig arbeitet er im Labor für molekulare Immunologie in der Gastroenterologie. Und dieser Spagat gelingt nun, um eine Forschung zu betreiben, die wirklich wichtig ist. Es ist sehr wichtig, dass wir wissenschaftlich aktive Ärzte und Kliniker haben, die sozusagen den Spagat zwischen der ärztlichen Tätigkeit und der Forschung machen können.
So, dear ladies and gentlemen, dear members of the advisory board of Jung-Stiftung, dear Professor Dimmerer, dear Mr. Spittman, thank you for the honor to be here. As you heard, I'm a clinician scientist and I'm working at the Department of Surgery and First Department of Medicine at the University Medical Center Hamburg-Eppendorf. I'm going to present you the next time my project about tissue-resident immunity and metastasis, and our aim is to find new immunotherapeutic strategies in organ-targeted metastasis. So as you know, colorectal cancer is the 3rd most common cause of cancer mortality worldwide, and metastasis is a key determinant of patients' outcome. So approximately 50% of patients with colorectal cancer will develop liver metastasis, and until now there are no sufficient immune therapies available for the majority of the patients. And how the metastasis is developed, so there is a metastatic cascade with different steps that we have first a primary tumor and the cancer cells that invade and intravasate into the blood circulation. Then from the blood circulation they use this as a way to extravasate into the target organs like liver or lungs, and there of course they face the first immune defense, that they are the tissue-resident immune cells, and they develop at the end micrometastasis or macrometastasis. So what are tissue-resident immune cells? Are cells that they express specific markers and they are the integral part of the immune sensing network and protect us as the main role of them is to protect us from infection. The role in cancer and metastasis until now is unclear. And I would like to start by showing you the first results that we have about interleukin 22, a cytokine that we know already that plays an important role in colorectal cancer. We found out that mice lacking IL-22, they developed less liver metastasis compared to wild-type littermate controls. And this was in an experimental model that we have induced liver metastasis in mice by injecting cancer cells into the spleen, and after 21 days the mice developed liver metastasis. So in the other important step of the metastatic cascade, in the extravasation step, we found also that mice lacking IL-22 and IL-22 signaling, they had reduced extravasating cancer cells into the liver parenchyma. And this we did with a flow cytometry assay that we injected marked cancer cells labeled with green fluorescent protein, and we can detect into the liver. The next question that we would like to answer was, what is the source of interleukin 22 during this important step of metastatic cascade during the extravasation? And by using reporter mice that we have in our lab, we found out that these are tissue-resident NKT cells. And this is an experiment that we performed by marking the circulating cells with CD45 in vivo staining. In order to verify our finding, we then used a state-of-the-art experiment that we did in collaboration with Professor Richard Flavel in Yale University. There we used mice that we pair together, and we inject PBS or cancer cells. These mice, they have different congenic markers, and we can detect which cells are tissue-resident cells into the liver and which cells are coming from the blood circulation. There we found also the same, so the main source of IL-22 in the extravasation step are the NKT tissue-resident cells. So for this reason, we hypothesized that tissue-resident immune cells in the target organ play a central role in metastasis formation. And in order to identify these tissue-resident immune cell subtypes and their cytokine products in metastasis formation, as a first aim, we had to transplant liver or lung, so to use orthotopic organ transplantation, because together with the organs, we transplant the tissue-resident immune cells of these organs, and we can then detect into the circulation, but also into the organ target of metastasis. This is two methods that I learned from Professor Angus Thompson in Pittsburgh University and from Wolfgang Wückemeyer from Freiburg University. I would like to emphasize their important support and help in this in my learning curve to establish these methods in University Medical Center Hamburg-Eppendorf. And I would like to share with you the first experiments after doing liver transplantation, that we can detect these tissue-resident cells, that they are coming from the liver transplant into the recipient. And these cells are, as we told before, they express specific markers. Here I would like to introduce and show the liver transplantation method. So first we have to prepare the liver donor. And we start with the vena cava anastomosis. This we are doing with the cuff technique. These cuffs are handmade from, for example, catheters that we use also for patients, so with different diameters. And then we have to stop also the blood circulation by putting a suture to, then when we reperfuse the liver, to start with a portal vein reperfusion. And then we prepare the portal vein, also with a cuff. All this procedure is under a stereo microscope that we use magnifications 25 until 41 times in order to have that. And then we introduce also 10-0 sutures in the suprahepatic vena cava. Then the liver is ready for the transplantation, and we go to the recipient. That we clamp already the portal vein, then the vena cava, the suprahepatic vena cava. And then we start to remove the liver from the recipient. By cutting first the portal vein, then the vena cava in this step. And then we remove the liver in order to have the liver transplant from the donor into the recipient. And we start with the anastomosis of the suprahepatic vena cava on the upper part with 10-0 suture. And then we introduce the cuff of the liver donor into the portal vein. and we ligate this cuff. And then is coming the cuff of the vena cava that we have also to introduce into the vena cava of the recipient. And this time is also the time of reperfusion. So the liver is becoming again red like before. And then we remove the clamp of the suprahepatic vena cava. This is the main reason of complications. So if there is a small problem in the anastomosis, then we cannot repair. So we have to have an excellent anastomosis. And then it's the vena cava anastomosis. And at the end, we have to do the bile duct so anastomosis. We use also a plastic stent for that. And the idea is the same. We introduce the stent of the donor into the recipient bile duct. And of course, we are going to perform these experiments in order to identify the tissue-resident immune cells subtypes, and by distinguishing them with a different congenic marker, so with CD45-1 and CD45-2. And after knowing which cells are important in this procedure, so during extravasation step of metastasis or during metastasis formation, we would like to make functional experiments by using CRISPR-Cas9 technology to knock out specific genes after knowing which genes are the candidate genes. And of course, in this procedure, we have to include the important cytokines that we can detect with our reporter mice that we have already in our lab, and except of the role of IL-22 that we found that plays a pre-metastatic effect in the metastasis formation, we have to check also IL-17A, IL-17F, IL-10, and interferon gamma. And we use for this reason liver transplantation and lung transplantation with a different cytokine reporter mouse. And here I would like to show you the lung transplantation procedure that we can transplant only the left lung of the mouse. And this is a big advantage of the lung transplantation because always we have the lung of the recipient and the lung of the donor. And for example, in a metastatic formation or in an infection model, we can distinguish between the two lungs, the immune subtypes of residency. So here we prepare first the pulmonary vein, then the pulmonary artery. And we use, again, the same technique, so the cuff technique that we can introduce in the pulmonary vein, the cuff, as I saw here. And then the artery, so also a cuff for the artery, 26G cuff. And we can start the reperfusion of the lung. And at the end, we introduce the cuff of the bronchus, that the lung is again functional. We have to use a positive PEEP and then close the thorax of the mouse. And our last aim, of course, is to translate our findings using humanized mice and human samples of liver and lung metastasis that we have the possibility to get from surgical department. The humanized mice is also a collaboration with Professor Flavel, that as you can see, we have used different cancer cell lines in hematoxylin eosin staining. We can induce liver metastasis, and these mice into the liver parenchyma express immune cells that are human immune cells. And we find this a very nice tool in order to do, after the description and the characterization of liver and lung metastasis in humans, a functional experiment in a humanized mouse to check our hypothesis. And our long-term aim is to find new therapies preventing or treating metastasis formation, and this is a unique possibility that we have in the University Medical Center Hamburg-Eppendorf, because we have a facility for functional experiments with mice. We have very talented colleagues that they can perform single-cell sequencing analysis and bulk sequencing analysis. That we have the surgical department that we can get samples from humans with this disease. And at the end, if we have all this, we can close this puzzle by performing experiments not only in humanized mice, but also checking these new therapies in humans with late stages of liver or lung metastasis. And at the end, I would like to show some few things for my career. So I did my studies in Greece. So I got a bachelor of nursing and 2 masters and my medical degree. And then after finishing my PhD, it was a real blessing to meet Professor Samuel Huber, who gave me the opportunity to continue my research here in Hamburg and to combine with my clinical duties in surgical department. So during my postdoc, I did a training in Yale University and in Pittsburgh University, and with a big support of different foundations and from University Medical Center Hamburg-Eppendorf, I managed to do my application for the Jung-Stiftung Foundation and for science and research, and I find this a big step for my career. Last but not least, I would like to thank all my mentors back in Greece, my PhD supervisor, Professor Stavropoulos, my colleagues here, so Professor Samuel Huber, Professor Nicola Galliani, and Professor Ark, that we have a nice collaboration in different projects. Of course, I would like to emphasize the freedom and the support that I got from Professor Itzbiken, Professor Mann, my mentors in surgical department, Dr. Lee, Professor Perez, Dr. Melling, Dr. Tahici, and Dr. Gatman. The very important mentors for me, Professor Angus Thompson, Professor Flavel, and Professor Guckemeyer, that they have taught me all these microsurgical techniques, and we can now perform this project in Hamburg by having the support of Jung-Stiftung for science and research. And of course, Professor Kobold, that we did the last year's collaboration in a project, and Professor Gondolesi, that I was also in Argentina to learn small intestine transplantation in rats, and for his big support there. Of course, all the foundations for their financial support. And I would like to thank you for your attention. I would like to thank one more time Jung-Stiftung for science and research. It's a great honor for me to be here, and this is a project that can give to patients with cancer and metastasis hope for new therapeutic approaches.